Welcome to Lesson 5 in Week 2, Module 2, dealing with the history of regulation and legislation with respect to consumer health information technology. In this lesson, we'll talk the third lesson that relates specifically to the Cures Act, and we'll talk about FHIR, the protocols for exchange of information, as well as implementation broadly of the Cures Act, and we'll consider how it impacts the present state of an evolution towards an expanded world of consumer health informatics. The Cures Act says that organizations must implement FHIR, I'm just going to call it FHIR, by December 31st of 2022. That's about a month ago. So what is FHIR? The Fast Health Interoperability Resources. What it really means is it's the standard for exchanging information following that US DCI set of data. As it says right here, that's perfectly clear. Fast Health Interoperability Resources. I don't really know what that means. The standard defines how healthcare information can be exchanged between different computer systems, regardless of how it is stored in those systems. That really means it's an API. And so oftentimes I will refer, and the literature refers to, when they're switched between talking about FHIR and APIs for exchange, it's the same thing, give or take a little subtlety. It's really the same idea. It allows healthcare information, including clinical and administrative data, to be available securely to those who have need to access it and those who have the right to do so for the benefit of patient receiving care. Standards development, HL7, uses a collaborative approach to develop and upgrade FHIR. But remember what we said a little while ago. One of the exceptions for not sharing involves when the information that might be in that record is not prescribed by FHIR or by US DCI. So even then, it relates to what is defined as personal health information, and that's reasonable, but isn't necessarily everything that will be included, particularly when we look at consumer health informatics that goes beyond a pure clinical approach and gets into social determinants of health, housing, food, environment. Are those defined? We'll be talking about that and we'll be looking at it. Also, FHIR is based on internet standards widely used by industries outside of healthcare. I got to admit, I love this because as some of you may have heard me say in the past, there is a sense in healthcare that we are different, implying perhaps we are better, but certainly that we are different. I recall a case when we were dealing with certain standards under high tech for breach notification. So if your system, whether it was a consumer health or any system, is compromised and private information could have been breached, you have a duty to notify those whose information was compromised and to give them some remedies. Now that rule was established in about 1996 in California, the first time, a bill called California Senate 1386. Well, that was so appropriate and successful that it was adopted by many other states, then adopted for commerce by the federal government through the Federal Trade Commission, and finally was adopted through high tech in the healthcare industry. And so I went to some of my early healthcare clients and said, we got you covered. We can help you with this. We've done it for several years. We've done it for a decade in other industries. And the first time I made that argument, feeling I was on solid ground, the executive said, this is healthcare. You have not done this before. Our information is more important, more sensitive. I don't care what you learn someplace else. This is a different thing. So I learned my lesson. After that, I went to the next client and I said, we have a unique solution to this unique problem that is specific to healthcare. let me describe it to you, or let me show it to you. And all we've done is change the logos on the same stuff we've been doing in other industries for 10 years. So I'm really excited to see here that in the published literature, it's recognized that FHIR is a standard built on other industries, and in this case, particularly the REST approach that describes how individual packets of information, which are termed resources, are shared. So then they go on, by adopting existing standards and technologies already familiar to software developers, FHIR significantly lowers the barriers to entry and makes exactly the point I was trying to make all those years ago. So what are the advantages of FHIR? It's pretty self-evident, but a strong focus on fast and easy implementation. For example, in Python, there is a library for FHIR. I haven't used it yet. I'm aware of it, but it makes sense that it would be there. Let's see, developers have reported that they can that have experienced simple interfaces being implemented in a single day. I like that phrase, but I'm not sure what a simple interface is. In my experience, almost no interface is simple, whatever that might mean. Therefore, I expect it would take more than a day, but hopefully it takes it less than if you didn't have the API to do it. Free with no restrictions, support from major vendors, because the government said thou shalt do this. Many free online downloadable tools. Again, the Python library is, for me, always a handy place to go. Many public examples help to kickstart development of new applications using these APIs. Interoperability out of the box. In other words, it works like it's supposed to. An evolutionary development path from earlier HL7 stuff. Yeah, I'm not sure. Coming from the clinical document architecture, the CCDA, and a strong foundation in other standards that we all know somewhat from technology, and is concise and easily understood online applications, at least compared to other online applications. Depends how it's written, I think, depends how it's implemented. A human readable serialization format. So if we started off with a CCD that was purely a print format, then we figured out how to make it go machine to machine across a network. Now they're saying, and you have to be able to make it machine readable, meeting back to that original need, as well as all of the connectivity needs we see in between. And finally, it does have a global community to assist. And if you go to the major conferences, PIMS, to a lesser extent, AMIA, and some of the others, certainly the HL7 conferences, you'll have some great tutorials, great people, great discussion about that as a part of that larger community. Now let's talk about the timeline for the Cures Act. Where are we and where are we going? Now this is really, remember, it was passed in 2016, but this focuses on, excuse me, on the period beginning in 2020. And that's because, frankly, it took a while to be able to develop the regulations, proliferate those, get them into the vendors, get the vendors to then deploy them, go through a couple of cycles of refinement, and then finally begin to say, all right, now we're going to hold you providers accountable for meeting these standards. That took until 2020. So for our interest, what we're really concerned about here is beginning really in April of 2022, not quite a year ago. The first attestation to conditions required for certification. So the standards under Cures Act for technology use, the first certification, attestation to say we have done this was in April of last year. December 31st, as we've already seen, was the deadline for which the FHIR API capability must be available. That means it must be available in the certified vendor technology, and that technology must be available to the provider, 2 levels, in the technology and in the deployment. That was just this past December. And then, of course, they have to submit initial real-world test results and finally demonstrate by the end of this year, EHI export capability must be made available. So one is saying we can meet the standards. The other, a year from now, is saying we must demonstrate and we must show that we have the ability to, in fact, exchange information not just between providers or providers and payers, but also with consumers. And at the same time, down here under the applicability of information blocking, EHI information is limited. That goes back to 2021. Now here's the big one. As of October, just this past October, the EHI definition is no longer limited to the EHI identified by the data elements represented by USCDI. So let's work with this. Back in 2011, the first stage of meaningful use for interoperability required that you print a piece of paper and give it to the patient with these 11 items on it. Going from there to now the present state, let's say prior to this past October, where you had to be able to not demonstrate transmission, although that's because that's December, but you had the ability to show you could meet the FHIR standard for all of the data elements that were in the US CDI. And as I've said, I haven't studied how the US CDI addresses the broader range of topics. When you go from physical health to mental health to addiction, addiction to social determinants of health, social determinants to diversity, equity, and inclusion. How does US CDI respond to each of those? How inclusive is it of how much standardization is there even in those other areas? Well, here's the answer. The definition is no longer limited to just those items. So now they're saying when we think about FHIR applicability, when we think about health information exchange, we are thinking about it in the entire universe of related information that might be included, represented by, not just that represented by US CDI, but going beyond that. And how are we doing in this? Well, this closest I could find was last August, early August. This shows relative to the certification criteria, and they're still using the 2015 criteria, but now they're saying criteria to be available by December 31st. So it's pretty recent current criteria. As of last August, 7% could share information. That's the standardized API for patient and population services. That's FHIR. Now, we're going to have we're kind of looking at this at several levels. What percentage of the vendors have adopted these technologies? What percentage of providers have adopted these technologies? And what percentage of the population are served by these providers? So kind of three ways of looking at how well have we proliferated and how far are we relative to these deadlines. But you can go through each of these: encryption of authentication, auditable events, clinical quality measures. 24% meet the standards for clinical quality measures. What this tells me is an awful lot of organizations, as of August at least, were not prepared to maximize their revenue by scoring high on all of these metrics. From the same article, interestingly, it says, as of August 1, roughly 5% of certified health IT developers have updated their technology to certified API technology, FHIR. 5% of the vendors. However, those 5% support 6% of inpatient and 77% of ambulatory users with their health IT modules, respectively. Why does that matter to us for consumer health informatics? Because again, going back to the picture of the Venn diagram with the three circles on it, If we don't want to be a freely spinning wheel, we either have to be a part of the EHR or we have to exchange data with the EHR. And given the present state of things, I think the better strategy is to develop the independent technology, but prepared to exchange information with the EHR, with the network. And that means all of these standards apply to us. That's both a huge opportunity and a discriminator, a competitive advantage, as well as a challenge, a place you have to invest, skills you have to acquire, albeit that it's a nice thing you can do on Python in under a day. I believe they're lying. But we have to consider it, and we have to make it allowed for that in the design and in the role that we expect to play. It may be a significant competitive advantage. Given equal functionality, if you say, and I meet FHIR, it's clear you are in the leading edge of your technology and in your ability, even though your focus is purely as a consumer health informatics platform. So what does it all mean? What's the takeaway from it? I think this is an immense opportunity for us right now. And it has from 2016 to early 2023, and we're still in the throes of it. We're far enough along that we can see that the runway is clear for 3 years, 2 to 3 years. We can see what role FHIR will play. We've had the development of the tools to make it happen. We don't see a clear, compelling argument for consumer engagement. But again, coming out of COVID, we see a real opportunity to go forward. The barrier that we're going to really have to deal with is how do you make technology fit into true evidence-based practice? And with that, what's the implication for FDA approval for some technology? So notice how I'm not spending my time yet talking about, gee, what does the thing do? I'm saying this is the surrounding environment, the context into which we must think about how we would place our brilliant ideas. And with that, I believe we are done except for an assignment, and then we will be ready to move to week 3. So here's your assignment, and I'm calling this assignments 1 and 2. So I don't want to make it just go back to for the number of points for one assignment. I think we have 4 assignments, something like that, that I want to have of these early assignments. This is going to be 1 and 2 because there's enough here that I didn't want to make it a 1-week assignment. So in 4 pages or so, less is okay. Don't get hung up on that. If it goes to 4.5 or 5, use what you need to say what you want to say. Describe how the U.S. CDI supports or does not support information from the following domains: social determinants of health, diversity, equity, inclusion, and mental health and addiction. I don't want you to go down the rabbit hole of a really deep dive. You should be able to find a fairly quick summary statement for each of these by looking at a part of the US CDI and saying, this is what they prescribe. Remember, what we learned just now from the timeline is that all of these principles apply not only just to US CDI, but beyond US CDI. I think it's important to know what's in it and therefore will be covered by reasonable standards so that we can anticipate what we might do with consumer health information, particularly when it comes to diversity, equity, inclusion, or social determinants that might not already be in US CDI. Consider the following broad questions. Does the US CDI have specifications specific to each of the above? If yes, where did those specifications come from? Did almost everything, as we're seeing, rips off from something beforehand? Tell us where it came from so we have a chance to then consider the evidence base for those definitions and how they fit into the industry. Are they structured data sets or are they physician notes? Again, that's a notion that we consistently see. Structured data sets, fixed number of characters, drop downs, more clear what the terminology need to be, as opposed to physician's notes, which are free form text. And as we think about the role of AI and other technologies to use this information, knowing whether it's structured text or physician's notes is absolutely critical. Don't beat up each and every one, but give us a sense of how that USCDI uses these and what kind of comments, or what kind of data this is. And the real question I want you to think about is, how will USCDI affect clinical health informatics with respect to these areas? And let's make that due at the end of day on February 5th. So you really have all of next week to work on that, and don't go all nuts. Remember my rule. I'm going to give 80% if you put in a paper anyway. So these early assignments, I'm not in trying to test what you know. I want you to get dirty with it. I want you to experience this stuff in the way that your boss might ask you to in the real world. So if you run into it and say, I couldn't find anything on this, and this is what I don't think there is anything, that's okay to say. Now, if you're the only one of 35 or so students that said I couldn't find anything, well, that's not so good. But if there isn't anything, and there may well not be, or there may only be 10 fields, it may be a really lame kind of a thing that you find, or it might be really comprehensive. Don't get all hung up about it. Tell me what you found after a reasonable investment. Tell me what questions you have, what concerns you have. This should be a dialogue. And you'll know your points aren't, if you make a reasonable effort of it at all, you'll get between the 80% and the 100%. And then I will spend my time concentrating on that dialogue with you through my comments on your paper, trying to respond or to clarify or to point you in other directions. That's how we'll build through this. And with that, that's it for Module 2, Week 2. If you have questions, I'm thinking about putting in a particular discussion tool in Canvas, either that or drop me an email. Looking forward to your thoughts. Today is Saturday. Did not have office hours today. We will begin having office hours next Saturday morning at 10 a.m. More details on that to come. Thank you all. Goodbye.